talking about, what is the waveform mean, what are the numbers mean, and how that relates to you in the field. And then the second portion, Dr. Giorgio has a lot of case scenarios, maybe not a lot, but quite a few, enough to kind of put together what I'm talking about and relate it to actual cases. So it kind of puts it all together, and at the end, hopefully you're feeling more comfortable with end-tidal CO2. I think what I like is you're seeing it more and more in use in the field when patients are coming in, since I do a little ER stuff on the side. So and I have a couple of cases that I kind of share that kind of relates to that. But why do we measure end-tidal CO2? What's the deal? Apparently it has been in use for a long time. There's been a lot of studies. This case study in 2005 was done in Florida, and it was done pre-hospital. There was about 1,500 to 2,000 cases that they used, and it compared field intubations that used continuous capnography to confirm intubations versus the patients that it was not used, versus non-used, showed 0 unrecognized misplaced intubations in the monitored group versus 23% misplaced tubes in the group that did not use end-tidal CO2. So that's a pretty significant finding. Obviously that's from 2005, but other studies that have been done verify that very same thing, that there are a lot of misplaced intubations when end-tidal CO2 is not used. So the reason we're here is because now it's mandated. We're going to be using it. It's easy to use. It's much easier than the old monitors that we had, where we had to like warm them up for 10 minutes and hope and pray that it was going to work when we connected it to the patient. Our monitors are so much easier now to use end-tidal, so there's no reason why not to use end-tidal CO2. When exhaled CO2 is detected, which is a positive reading for CO2, in cardiac arrest, it is usually a reliable indicator of tube position in the trachea. The American Heart Association now, in the last 2010 guidelines, definitely are encouraging end-tidal CO2. And when you're doing, a lot of times when you're doing your ALS, ACLS, they want you to mention that you're using end-tidal CO2. And I know some of you do ACLS and some of you don't, but certainly American Heart has realized that that is definitely a measurement that we should be using now. The value of the waveform. Granted, you get numbers. We also want to look at a waveform, and we're going to talk about some of the waveforms and the differences in how they look. But the value is it provides validation of the end-tidal CO2 value. You've got a number. Now you can actually see a waveform. It's a visual assessment of patient airway integrity. It verifies your proper ET placement. It's also an assessment for us who do transport, assessment of ventilator and breathing circuit integrity. And without a end-tidal CO2 without a waveform is like a pulse rate without an EKG reading. You can't really tell, I mean, you have a number, but you really don't know what else is going on. And so your waveform can tell you a lot too. The one thing I want to say prior to all this is don't get hung up on the number of your end-tidal. We're going to talk about numbers, but it is all about trending. When you are getting your end-tidal, what did you start with and what are you ending with? And what does that mean for your patient? So it's all about trending. What are we measuring? So anytime you have a patient who's intubated or you're concerned about them, we have our side stream now. Obviously we're using pulse oximetry and we're using end-tidal CO2. So oxygenation is how we get oxygen to the tissues. Pulse oximetry measures oxygenation. That's what pulse oximetry does. You can have a patient that's very well oxygenated, but they're not ventilating effectively. So just keep that in mind, especially with your patients who are intubated. Ventilation, which is the movement of air, is how we get rid of our carbon dioxide. And carbon dioxide is obviously carried back through the blood and exhaled by the lungs through the alveoli. That's what capnography measures. Capnography measures ventilation. And that's what's important, especially when you have a patient who is intubated or you've got them on CPAP or you're using your side stream end-tidal CO2. You're measuring how well they're ventilating. How many times have you had a patient who is a COPDer and they are working so hard to breathe, their stats are 100%. That's a great number. You're like, woohoo, but you know that that patient is probably going to need to be intubated as soon as they hit the ER. So if you did if you put them on end-tidal CO2 or you had a side stream, you would then see that probably their end-tidal CO2 numbers are 60, 70, 80.
Yeah.
So,
Yeah. Anybody who graduated from my paramedic program will know I'm going to take you back. Where do you think kapnos comes from, that word?
Greece.
What language? Greece. That's right. Like the father in my big fat Greek wedding. Give me any word and I'll tell you what I kapnos means smoke in Greek. And what is CO2? It's a product of combustion, okay? It is actually what metabolically goes on in the Krebs cycle. CO2 is blown off by the metabolism of oxygen and glucose. And therefore, that's my simple way of looking at it. Kapnos, if you go to Greece, you'll see signs everywhere now because they're part of the EU. Mi kapnizete, don't smoke. Kapnos, no smoking, no smoking. Of course, the Greeks all ignore the signs. That's the simple way to look at it. What we're detecting is actual combustion going on of our metabolic machinery, and we've got to blow off that CO2. That's much different than just oxygenation. Oxygen is bound up in hemoglobin. We can store lots of it in the bloodstream. CO2's got to get out quickly, or it quickly builds up in the bloodstream. There's no storage for it. And when we later on just demonstrate the oximetry versus capnography, you'll see what a huge difference there is between the two. So they don't really equate. You got to look at both of them. You can't do any one, though, by itself. Sorry, Lord, I just couldn't resist. I always got to give you a Greek lesson.
Alrighty, so capnography and pulse oximetry, just kind of a little difference here, and kind of a review of what we were just saying, is end-tidal CO2, or CO2, detects apnea and hypoventilation immediately. And I think that's the thing about pulse oximetry and end-tidal CO2. Like Dr. Giorgio said, we're going to do a little demonstration after. I'm going to have a monitor, and we'll show you how quickly, I mean, it's immediate that your end-tidal CO2 is 0, but your O2 saturation stays the same for maybe a minute or two, and then it starts to go down. So it's quite immediate. It reflects ventilation, like we already said, but it should be used in conjunction with pulse oximetry. The O2 saturation, it reflects oxygenation, obviously, but there's this 30 to 60 second lag time. I've even seen longer. And it's just kind of a slow progression where it goes down, down, down. You're thinking, oh, 90, 92%, okay, we're still kind of hanging in there. But their end-tidal CO2 will be very poor or none. And obviously, O2 saturation should be used with capnography. Indications for end-tidal CO2 monitoring. We're going to talk a lot about the intubated patient because pre-hospital, that's where it comes into play. The end-tidal CO2 is a validation of proper intertracheal tube placement, detection and monitoring of respiratory depression. So you've got our patients that we all take care of all the time who've taken all their meds at home, and now they have respiratory depression because of that. Hypoventilation, sleep apnea, procedural sedation. We use it in the ER a lot now with patients that we're using procedural sedation on. That doesn't really apply in pre-hospital, but still, that is another use for it. And an adjustment of parameter settings in mechanically ventilated patients. So for our ventilated patients that we're transporting on the vent, we can make adjustments based off of, some adjustments can be based off of end-tidal CO2. So what are the kind of normal numbers? Okay, it's like anything. The normal numbers that we talk about for end-tidal CO2, it's kind of like, when you talk about heart rate, everybody goes, what's a normal heart rate, in the lay people? Well, 80, okay, but we all know that there's a whole lot of different heart rates out there for various different reasons. For end-tidal CO2, your values, 35 to 45 is kind of like a standard numbering system that everybody likes to go by. So 35 to 45, we like to kind of keep your patients in that realm. But again, it's all about trending. If your patient was 65, 70, and now you've got them on CPAP or you've intubated them, and now your numbers have come down into the 50s, you're doing good, because now you're trending in the right direction. So it's not to get hung up on the 35 to 45 number, it's trending and where are you going with that. If they were CPR and you're doing CPR and your patient is intubated and you're ventilating that patient effectively and your numbers have been 8 to 10 and suddenly you get a spike to 35 or 40, that tells you you've probably got pulses back and now things are trending in the right direction. So there's a lot of reasons why your numbers could be different, but your normal values are going to be 35 to 45. And this is kind of showing that basically when you do a blood gas and you can also get your end tidal, many times those numbers correlate very well. Not that you're going to be doing blood gases in the field, but it's just sort of to show you that the end tidal CO2 values are very accurate. So what about this waveform? Sometimes I've heard people be a little bit stressed about the waveform, and what does the waveform mean, and what kind of waveform should I have? They call it the square waveform, and that's exactly how it looks. On a patient that doesn't have any other issues going on, you might see some other waveforms in patients who have asthma or COPD, but this is your basic waveform. And this is, I just want to show this so you understand what you're looking at on your waveform. So the AE area there is just that CO2 free dead space area. And then B to C, as you go up, that's your expiratory upstroke, so you're taking your breath. C to D is your expiratory plateau and exhalation of mostly alveolar air. And at D, that's where your end tidal CO2 number is coming up. So at that point where they're doing your expiratory phase, that's where you're going to get your end tidal CO2 number. So whatever that is, 50, 45, 20, nothing, whatever it is you get, that's where that number is at. So D is your end tidal CO2 value, and then D to E, your inspiration begins. So that's just a really basic explanation of your waveform so you know what you're looking at. Really what you're mostly concerned about is what is my number and where is it going. But that is a normal waveform. Any questions at all? Okay, end tidal and cardiac resuscitation, and that's really that study that they did in 2005. That is what they were really looking at. They were looking at validating that your tube was in the trachea and also survivability based on your end tidal CO2 numbers. And there's been a lot of really good studies, and they're actually very accurate. End tidal CO2 and cardiac resuscitation, the non-survivors, and this is with obviously CPR in progress with an intubated patient. If their average end tidal CO2 maintained between 4 and 10, those patients, none of them usually survived. The greatest chance for spontaneous circulation occurs when the end tidal levels are maintained above 20 during cardiac arrest. Survivors, the average end tidal CO2 is above 30.
Yeah. So you get the concept here? If some cells are still alive, in other words, right? They're producing smoke, okay? They're metabolizing. That's the point. So therefore, you get a high end tidal CO2. It's not that the CO2 somehow makes you survive, all right? It's just a surrogate marker. It's just a reflection of the fact that there are still some cells alive. So what it's helpful more for is you're still getting ETCO2 above 20, then you actually know you've got some tissue that is metabolizing still while you're doing CPR. This is somebody we have a better chance of resuscitating. It's not that the CO2 actually made them survive. It's just purely a reflection of the fact that we've got something going for us.
There was we had a really good example of this last Thursday. I was working at Twin. We had a CPR in progress come in. It's a patient well known to Twin. And they came in, the patient was intubated. They were using the auto pulse. And on arrival, the medic, and it was Robbie, and he did a great job, and that's why I'm bringing up his name. You were there, right? That was a very good call. On arrival, the first thing Robbie said was, the end tidal is 14. And I'm like, right on, because that meant he was using the auto pulse, the patient was intubated, copious secretions. I mean, he had there was a lot to deal with on that patient, and it was a huge mess with the whole family and everything else. But the bottom line was, and then I looked at the PCR, he had it documented wonderfully. I mean, the first end tidal was 10, then he got 11. I think he got as high as 14, and then it went back down. Did that patient survive? No. But when the patient was in transport and I took the radio call, the ER physician said, okay, we're probably gonna call this, but the first thing I wanna do is just make sure the tube's in place. And I'm like, that entitled better be on, and so he was. And when he arrived, that's the first thing Robbie said. Now we took it off because there was tons of secretions, and that's the other problem, is many times if you have a lot of secretions with a patient that's on entitle, you need to take it off because it's probably gonna have a failure, and that's what happened. It got a dash at the very end, I think, and they took it off. But the bottom line is, it is a wonderful tool. It doesn't mean your patient is going to survive, like Dr. Georgia said, but it gives you a good feeling to know that you've got a device that you can check constantly. And remember, the big thing too is you're moving these patients so many times. You've moved them into the ambulance, you're moving them out of the ambulance, you've got people running around you, you're moving them into the ER and moving them again. Make sure you document before you move them and after you move them, your end-tidal CO2 numbers. Because the other thing on this, I looked at the PCR, he documented all of his end-tidal CO2 numbers. The O2 sats were in the 70s the whole time. Well, he's not oxygenating anymore. This guy's been down now for probably 25 minutes, but he's got some CO2 left, so we've got numbers that are reflecting that. It's 10, it's 9, but you know your tube's in. And that's what it was all about at this point. You just knew you were ventilating your patient effectively, using your end-tidal CO2, and we called it within like 5 minutes after the patient got there because this patient wasn't going to survive and he had been down for way too long. But I just wanted to share that because it was a really, really good call. And with the auto pulse, if you have an auto pulse and you don't have a battery issue with your auto pulse that day, I think we kind of solved that problem, huh? With the auto pulse, it gives great compressions, and so you get good numbers if you're going to get them with your end-tidal CO2. So just keep that in mind. But on this vein too, the survivor rate, usually their end-tidal is above 30. That means they probably just went down, and more than likely those patients get ROSC very quickly. Whereas this patient, we were not going to get ROSC on. Okay, so our cardiac arrest and end-tidal CO2, the reason that the end-tidal CO2 would ever be 0 is because the tube's in the esophagus. If you get a 0 number and you just have a straight line, usually your tube's in the esophagus or you're not even ventilating your patient at all.
When you see some of the waveforms will show you, though, for misplacement, you'll go, well, wait, there was a little blip there. That's just a burp, okay?
Yeah.
So, there's some CO2 that got into the stomach, but you will not get anything sustained. Okay, so don't let that little blip fool you. You're going to see it quickly flatlines out. So you can't store that much CO2 in your stomach.
Exactly.
Dr. D, how long until you have total stopping of all metabolic activity that we would actually, let's say you put it in a cadaver, you're going to get a 0. So how long does it take on the average death for that to happen? Any idea?
In terms of metabolic activity producing CO2, it'll depend on the tissue, and we haven't done Ha on that, but you're talking from complete lack of perfusion till cell death. It'll be 5 minutes for gray cells and to actual cell death. That's a tough question. To tell you the truth, once you've lost your O2 and your perfusion, you're going to stop CO2 production by that cell because it'll go through the Krebs cycle real quickly, use up the glucose, and then metabolically, it's going to try to use some other substrates, but it's not going to get very far because it can't mobilize glycogen from the liver or other things. So it's good. I hadn't really thought about it, but in 10 minutes, you won't have any CO2 production. So it's not that the cell's dead even yet, it just can't produce CO2 because it's not getting any of the substrates from metabolism. So I'd say, probably 5 to 10 minutes even if you got a complete lack of perfusion. But if you're doing CPR, you're getting some perfusion, the cells keep on trying to do some metabolism for you. Are you asking the question though in terms of you come on somebody, intubate them, and...
Well, I more so just like at what point would CPR, start, the perfusion from CPR and all that not have an effect, not produce CPR? or CO2.
Yeah. When you first start CPR, you're going to get some CO2 production because you're flushing out what's just in the vascular system at that point. But a few cycles of CPR, you're going to start seeing that CO2 just plummet. Julie, did you have